how to diagnose a case of testicular tumor. As usual, we have some clinical features and we do some investigations. If you see, the most common symptoms, that is a complaint or symptoms: painless, gradual enlargement of testis. And very rarely, the patient might complain of acute pain due to sudden necrosis or hemorrhage inside the testicular tumor. Otherwise, the most common complaint is painless, gradual enlargement of testis. Then what you will find if you examine the testis, that is, what are the signs? Suppose there is a tumor inside the right testis. Okay. Number one, it is scrotal swelling. We palpate the vast difference, and if we are able to feel the vast difference, then we can say the swelling is not coming from inguinal region, rather it is coming from scrotum. If you feel this tumor, then the tumor will be hard, non-tender, and irregular. Okay. Okay. See, this testicular tumor is solid, right? This is not a tumor containing fluid. So whenever there is a solid tumors, then we don't find fluctuation positive or trans-elimination positive. What is that? Fluctuation is negative, trans-elimination is negative. So whenever there is a fluid inside the any swelling, then if you pass the light through this swelling, light, by using small torch light, then it will glow, indicating there is a fluid inside. But as it is a solid tumor, this will not glow. That is indicating this is not a fluid. And whenever we feel the testis, we feel it by 2 fingers and try to feel the consistency. It is cystic if it is containing fluid, but it is not containing fluid, so you cannot feel or fluctuate the fluid. That's why the fluctuation test is negative. I'll show this test in a video later on in hydrocele chapter. Okay. If you lift these testes, if you lift it, then it feel heavy on lifting, and the patient might say, I've lost sensation on touch. So these are the features of testicular tumor of a young adult 30 to 40 will present to you with painless gradual enlargement of testis. On examination, you will find this is a scrotal swelling, and it felt like hard, non-tender, irregular swelling. And if you lift it, it is heavy, and sometimes patient may say, I've lost the sensation, testicular sensation, touch sensation. And the fluctuation and trans-elimination tests are negative because these are not a fluid containing swelling, rather it is a solid swelling. So these findings are suggestive of testicular tumor. Everything I have explained is exactly written over here, so you can go through this slide. As this is a testicular tumor, we always search for metastatic feature as well. So you know the common metastatic features. If it goes to lung, there is copper hemoptysis. Liver metastasis means jaundice and hepatomegaly. Lymph node metastasis, the para-aortic lymph node is very difficult to palpate. But if it involves the Burkitt's gland or left supraclavicular gland, then you can feel that enlarged, non-tender, hard supraclavicular gland. So if you find a patient with a testicular tumor and enlarged Burkitt's gland, then it is almost systemic disease. It has almost reached the system. So this is a very late disease. Okay. And as usual, like other tumors, If there's a metastasis, patient will have loss of appetite, anorexia, patient feel weakness, there might be anemia, and a significant weight loss like 3 kg in 3 months. Okay, so these are the features of metastasis. Sometimes patients don't have any symptoms and they are diagnosed accidentally. But suppose they went to doctor for other disease. On examination, then the physician found there could be testicular tumor. In some cases of germ cell tumors, you may find a patient might have gynecomastia due to hormonal imbalance, and also in some patient there may be a secondary hydrocele. What is that? Let me explain. See this picture. This is testis. Just outside the testis, there is a double layered structure covering the testis known as tunica vaginalis. Tunica vaginalis. And if the fluid accumulate in these tunica layer, between these two layers, then it is known as hydrocele. Okay. And there are so many causes of hydrocele, so many causes. I'll discuss later on. But if the hydrocele is caused by testicular tumor, because see, a testicular tumor can invade these tunica and can cause excessive secretion of the fluid. So if a testicular tumor is associated with hydrocele, then this is known as secondary hydrocele. Let me tell you precisely, if a hydrocele is caused by any disease, like testicular tumor, infection, trauma, then it is known as secondary hydrocele. So in 10% cases, the patient might have hydrocele on presentation. Testicular tumor is a painless swelling, right? So whenever you get a patient with a painless scrotal swelling, then you must think some differential diagnosis. This is scrotum. I'm just drawing one side, okay? This is testis. This is epididymis. This is vas deferens. Okay. There's tunica vaginalis covering there. So, see here, if the fluid accumulates inside the tunica vaginalis due to any reasons, okay, due to any reason, primary or secondary reason, then this is known as hydrocele. Hydrocele is an abnormal accumulation of fluid inside tunica vaginalis. There could be a cystic swelling arising from epididymis, cyst of epididymis, okay? Or there could be spermatocele. Spermatocele means spermatocele. This is the swelling that arises due to obstruction of seminiferous tubule. These all swellings are actually swelling containing fluid. So you can say these are cystic swelling. All are arising from the content of scrotum. Whereas if there's a testicular tumor, then this will be solid tumor, right? Testicular tumor. And sometimes there may be a chronic inflammation of epididymis and testis, known as chronic, not acute, acute is painful, chronic epididymo-orchitis. These two are actually solid swellings. So these 5 are the differential diagnosis of painless scrotal swelling. So how to know whether cystic or solid? Obviously, by doing clinical examination, you can find in cystic swelling, the feeling is cystic, it is cystic. Consistency means the feeling is cystic. Cystic means just like feeling the balloon filled with water. So if you feel the balloon filled with water, the feeling that you get is cystic feeling. And if you use your 2 fingers to fluctuate, it is positive, usually positive. Fluctuation is positive. and transillumination is positive. But to confirm, you can do ultrasonogram of scrotum. One of the most common cause of chronic epididymoorchitis in our part of the world is tuberculosis. Yes, the testis and epididymis can also be affected by tuberculosis. To summarize, common causes of painless scrotal swelling. How to diagnose a case of testicular tumor? So we will follow the same pattern of diagnosis. That is, we have some investigations for diagnosis. There are some investigation for metastasis. And also there are some special investigation for infertility, or you can say investigation for fertility. So investigations for diagnosis. The first investigation that we do in the case of suspicious testicular tumor is ultrasonogram of scrotum, or you can say testis, same thing. It is 100% sensitive. It can easily identify the testicular tumor. Okay. Second one is serum tumor markers. Serum tumor markers like alkaline phosphatase, HCG, LDS, placental alkaline phosphatase. These we see, and you know these are usually increased in non-seminoma. Placental alkaline phosphatase is increased in seminoma, usually in the case of advanced disease. Third one is we remove the testis and send for the histopathology for diagnosis confirmation and to know the histological type. So to confirm diagnosis and to know type, histological type and staging. So removing testis in testicular tumor is not only a part of treatment, but also a part of investigation. You may be thinking, so why to remove testis to confirm? Why not to do biopsy? So see, this is testis. Suppose a patient has testicular tumor over here. The question is, can we do FNAC or biopsy via scrotal skin? And says, no, we don't do that, because if you puncture the scrotal skin and then puncture the testicular tumor, then you are going to do scrotal skin violation. That means later on, the testicular tumor may go to inguinal lymph node as well. And the problem of these metastasis to inguinal lymph node is you have to remove the inguinal lymph node during surgery, and that creates a lot of local complications. That's why we remove the testis. We remove the entire testis via inguinal route. That means, so we will give incision to the inguinal area, inguinal canal, and from here we remove it outside. Okay, not through the scrotal skin. So we don't give incision here and remove it. So we give incision at the inguinal region and remove the testis from that area and do orchiectomy. I'll show you the picture. Wait. These are the investigations for your diagnosis. The most confirmatory investigation is histopathology or biopsy, that is after orchiectomy or orchiectomy. And what about the metastatic evaluation? For metastatic evaluation, we always do abdominal CT scan. So again, you have to understand this. This is testis, testicular tumor. The most common route of metastasis is lymphatic route. And you know, these tumors will go to these retroperitoneal lymph nodes, preaortic, paraortic, interaortic cavern, like that. So whenever you have a patient with testicular tumor, always do CT scan of abdomen and pelvis, especially around the paraortic area, because we want to know whether that the tumor has involved these lymph node or not. Okay, this is important. We always do the CT scan of abdomen. CT scan chest. Why? Because if the tumor follows hematogenous route, then the lung is the first organ to involve. That's why you always do CT scan chest. And if there's a lung involvement, you may find cannonball metastasis. Liver function test we always do to assess the liver function, as well as it include alkaline phosphatase. So this also give you idea about the bone metastasis. These three we always do. Regarding bone scan and brain MRI, it depends on symptoms. If the testicular tumor patient presented to you with back pain, bone pain, fractures, then go for bone scan. If there is a headache, vomiting, seizure, then go for brain MRI. Otherwise, we don't do these investigations. Third one is fertility. The patient of testicular tumor are young at their 30s and 40s. They might have a plan for future child. So before doing any treatment, you have to discuss with patient regarding future fertility, or you can say future, conception. For that, you have to check the hormone status before surgery. We check testosterone level, we check LH and FSH, and also we do semen analysis. And once we see all these parameters, then we advise patient for sperm banking, such that the sperm later on can be used for IVF, and the couple might have children in the future. So see, what happened in testicular tumor is we remove the testis, affected testis, and after that we give radiotherapy to the abdomen or systemic chemotherapy. That may affect the other remaining testis as well. So the quality and quantity of sperm that you will get after treatment is very, very less and poor. That's why we suggest the patient to do this fertility checkup and store the sperm in the sperm bank. Sperm bank means it's a place where we keep this sperm in a freezer, such that we can utilize this sperm later on for in vitro fertilization. As like other tumor, you can you can do general investigations for fitness for surgery. These are the investigation for diagnosis. See this ultrasonogram, you can see here. This is ultrasonogram showing testis, and the hypoechoic area inside the testis is indicative of testicular tumor. These are metastatic evaluation we have already discussed. Fertility investigations and general investigation for fitness. How to manage testicular tumor? Obviously, we have to manage the testis. We have to give some adjuvant therapies after removing testis, and always consider sperm banking and testicular prosthesis. That means when you remove one side testis from one side, then it feels empty, right? Because there are two testes. Just like doing breast surgery mastectomy, what we do after that, we put breast implant. Like that, we also can use testicular implant or prosthesis, because to give a feeling of symmetry. Suppose a patient came to you with a history of gradual enlargement of testis, painless, and you did ultrasonogram and you are confirmed it is testicular tumor. Okay, tumor is confirmed. And then we have done all the investigations that you have to do. Then to confirm and stage, the first thing that we have to do is inguinal orchiectomy. So remove the testis through inguinal region and send for histopathological examination. And if the report come to you as seminoma, very common variety, then what to do, right? So obviously you have done the investigation like CT scan chest, you have done CT abdomen, so you have done all the investigation. Now you know the staging. Okay. So seminoma with stage 1, what will you do? Stage 1 means testicular tumor confined to testis. The retroperitoneal lymph node are not involved. So lymph node are not involved, only it is confined to testis. Then what will you do? Okay. So obviously we have already removed the testis, right? So we have removed it. See here. Now what to do? As it is totally confined to testis, not involving any other area, so some surgeons think, okay, let us keep the patient in follow-up, just follow-up. But still it is around 80% curative. That is, a patient, 80% patient will not have recurrence, but 20% may have. Okay, that's why the ideal treatment would be radiotherapy to retroperitoneum. That means give radiotherapy to lymph node here, not to testis. Here, you may think, sir, there is no metastasis. Why you are giving radiotherapy to the lymph nodes? Because there could be micrometastasis. Okay, that we cannot identify by CT scan. And if the recurrence occurs, the recurrence occurs at this site, these lymph nodes. That's why we have to give radiotherapy to these lymph nodes. Okay. And some may argue, why not to give a chemotherapy, a single drug chemotherapy, carboplatin, single drug, okay, drug chemo. But the ideal would be radiotherapy to retroperitoneal lymph nodes. Even though they are not involved, you have to give it to prevent a recurrence. And this is around 99% curative. Then what about stage 2? Stage 2 means by CT scan, we knew that a testicular tumor has involved the retroperitoneal lymph node. These lymph nodes are involved by these cancers. This is stage 2. The first priority is after orchiectomy. Obviously, we have removed this testis. Don't forget that. Okay, testis removal is a part 1, already done. We are discussing part 2. So here we have to add systemic chemotherapy by multiple drug known as PEP, combination of EP. Okay, in this the most important drug is this P. P means cisplatin. Cis-P means platin, cisplatin. Alternatively, we can give radiotherapy also. Radiotherapy to these area, lymph node. Okay, because seminoma is very much sensitive to radiotherapy. That's why in stage 1 and also sometime in stage 2, we can go for radiotherapy. But better choice would be chemotherapy, systemic chemotherapy. Stage 3 and stage 4, 3 means involving the Burkitt's gland and 4 means already a metastatic disease involving the other organ. In that case, the only option that you have is systemic chemotherapy. Systemic chemo by using those BEP or EP for 3 to 4 cycles, and you have to give palliative care if required. What about non-seminoma? Suppose a patient, 30 to 40 years old male, came to you with testicular tumor. You did ultrasonogram, found there is a testicular tumor, and you did other investigations. And to confirm, you did inguinal orchiectomy. And the report of histopathology came to you as non-seminomatous germ cell. It could be teratoma, it could be inguinal carcinoma, yolk sac tumor, or choriocarcinoma. Anyone. These all are known as non-seminomatous germ cell tumor. And if you see this investigation, CT chest, abdomen, then now you can stage the disease. Suppose a patient is having stage 1 non-seminomatous germ cell tumor. Again, stage 1 means the retroperitoneal lymph node are not involved. These lymph nodes are not involved. Okay, the tumor is confined to testis. You have already removed the testis as a first step here. Now, see, these non-seminomatous germ cell tumor are not that much sensitive to radiotherapy. They are not that much sensitive. Okay, so we can do here is RPLND, that is retroperitoneal lymph node dissection. That is, remove these retroperitoneal lymph node. A bit seems to be a bit aggressive surgery. This is usually done in USA, and those who follow American guidelines, they do that. A bit aggressive surgery. See, the problem in removing these lymph node are it causes a lot of complications like lymphedema, problem in the lower limbs, so many local complication infections, and so on. That's why some avoid these RPLND surgery in the stage 1. So those who avoid, they just follow up, and or they may add some chemotherapy as well. RPLND is the best choice. Stage 2 means there's a tumor in testis with involvement of retroperitoneal lymph node by these cancer cells, which can be seen by CT scan. Okay, this is stage 2. Stage 2 is straightforward. You have already removed the testis. Now remove this lymph node. RPLND is the best option for stage 2. Remove the retroperitoneal lymph node. Okay. Stage 3, 4, same as seminoma. You have to give systemic chemotherapy with BEP or EP, and you have to add palliative care if required. So this is the guideline for management of non-seminomatous germ cell tumor. This is some summarized version. The detail is too detailed for you, so I have just summarized from the European guideline so that at least you can understand the process. So we have discussed multiple times that inguinal orchiectomy, right? Why we say inguinal radical orchiectomy? See here. So what we do here at the beginning is we give incision at inguinal region along the inguinal canal, and once you see the spermatic cord, spermatic cord, which contain vas deferens, testicular artery, testicular vein. We just clamp it as near to deep ring. We clamp it. Once we clamp it, now these testicular tumor cannot metastasize to this lymphatics or this vein during manipulation. Once you clamp it, you bring the testis out through inguinal incision, like this one, not through scrotum. Okay, and once you bring it out, you cut it and send to histopathological examination to the pathology lab, and you stitch it and close it. This is known as inguinal radical orchiectomy or orchidectomy. If you are in doubt, if you want to confirm before removing, then we have a technique known as Chivasu's technique. What we do here, at the beginning, we do same. We open the inguinal canal, we identify the spermatic cord, we apply the clamp. Up to that, it is okay. You remove the testis from the inguinal region, it's okay. But before cutting the testis, we take biopsy from suspicious area after removing it from the scrotum. Okay, we take biopsy during surgery. So it's known as frozen section biopsy, frozen section. During surgery, we do that, send to the lab, pathology lab, and wait for report. If the report comes to you as a negative, there is no cancer, then leave it, don't remove it. If the report comes to you as a positive for cancer, then you continue to do inguinal radical orchiectomy. And after doing orchidectomy, we send again to the pathology lab. Now we send the entire testis for detail, histopathological examination. The predisposing factor for testicular germ cell tumor are cryptorchidism and Klinefelter syndromes. See this question. Among all the testicular tumor, the most radiosensitive testicular tumor is seminoma. See a young male with hard painless testis, ossifetubatin very, very high. The parotid lymph nodes are not involved. Okay. Ultrasonogram shows there's a tumor. Now tell me, what is your next step? We are clinically sure it's a case of testicular tumor. We are radiologically sure this is a case of testicular tumor. Now what you want to do now? We don't do FNAC or biopsy through the scrotum because of scrotal violation. That may lead to metastasis to inguinal lymph node. So no FNAC, no true-cut biopsy, no PET CT scan. We directly remove testis for confirmation and staging. True, because most of the testicular tumor are germ cell tumors. Seminoma is the most common variety of testicular tumor that arise in cryptorchidism. It is true. High inguinal orchiectomy is the initial surgery procedure. It is true. Alpha fetoprotein is markedly raised in all. This statement all is not true. Why? The germ cell means we have seminoma and non-seminoma, both are combinedly known as germ cell tumor. Non-seminoma, yes, alpha fetoprotein is high. Seminoma, no. So once the statement says all, that means it is saying us both seminoma and non-seminoma have high alpha fetoprotein. No, it's wrong statement. C is the answer. Usually in seminoma, tumor markers are not raised. If this is raised, then placental alkaline phosphate is raised in 40 to 60% cases of advanced disease. And in 7% cases, you will find increased SCZ. So if you have to choose one, then it is placental alkaline phosphatase. If you have to choose two, then it is A and D. a young male having scrotal mass. Whenever there is a scrotal mass or scrotal swelling, the first investigation is always ultrasonogram. The A is not investigation, it is a clinical evaluation. I'm asking you investigation. Whenever you get a patient of scrotal disease, the first investigation is always ultrasonogram. The most common variety of testicular tumor is seminoma. In children, the most common is yolk sac tumor. Remember that. Don't get confused. If I have asked you what is the most common variety of testicular tumor, the answer should be seminoma. If I'm asking you if it's age specific, here children, yolk sac tumor. If I've asked you the most common testicular tumor at the age of 60, you have to say lymphoma. So remember these things, okay? You remove the testis and then give radiotherapy to retroperitoneal lymph node. See over here, 27 years old man with left testicular tumor with 10 centimeter retroperitoneal lymph node. So this is stage 2 disease, stage 2. Okay, what is your treatment? Obviously, we have to remove the testis and we can give chemotherapy. They haven't given us the option of either seminoma or non-seminoma. Whatever the seminoma, non-seminoma, in stage 2, you can straight go for chemotherapy, no doubt. Okay. So this is the case of stage 2 teratoma. Testicular tumor involving those lymph nodes. So this is stage 2. And you know, we're talking about teratoma. Teratoma is non-seminomatous germ cell tumor. So what is the option for this patient? Remove testis, no doubt, and remove the lymph node. So the option is orchiectomy with RPLND. These are the references I have used.